Let's talk about International Childhood Cancer Day. This day, the 15th of February, and every other 15th of February is International Childhood Cancer Day. Let's talk about that. And joining us in the studio to have this conversation with us is Sidney Chahonyo. Sidney is the board chair of an organization called Hope for Kids. Good morning, Sidney.
Good morning.
Thank you very much for joining us in the Situation Room. I don't know how you want us to greet each other on this. Is it Happy International Childhood Cancer Day, or as we commemorate this International Childhood Cancer Day?
Either way is fine.
Right.
As long as people out there know that we are raising awareness about childhood cancer. Yeah.
Tell us about your organization, Hope for Cancer Kids.
Hope for Cancer Kids was started as a support group for parents who had children with cancer at Kenyatta National Hospital. And that was in about 2008. And with time, they realized that the needs they had, when one parent goes to complain, you don't get much traction. But when you go as a group, a lot more is accomplished. So it was registered as a civil society. And we've been supporting children who from low privileged families that can't afford cancer treatment. And what we do is we register them for NHIF. We work with community health workers and the nurses in charge in a lot of public hospitals. And they tell us these are the kids that have been diagnosed and they can't afford cancer treatment. Even that $500 for NHIF, they cannot afford it. So we step in and we pay the NHIF premium. And then they're able to get cancer treatment in public hospitals. Right now, we are supporting about 150 kids per month to get cancer treatment. Aside from that, we're involved in advocacy. We are involved in raising awareness and also just navigating them through the system.
When you say kids, what age group are we talking about?
We deal with children and adolescents from 0 to 19. I think the youngest child we have supported was 3 months old.
What kind of prevalence are we looking at here, and what kinds of cancers are we looking at? We know for women, we're dealing with cervical and breast cancers as the top two in the country. What are we looking at for children now, and how bad is the situation?
Sadly, there are no childhood cancer registries in Kenya and a lot of low and middle income countries. So the numbers we get are extrapolated. We get worldwide about 400,000 children a year diagnosed with cancer. And the top cancers that we have in Kenya, we have Wilms tumor, we have retinoblastoma, which is a cancer of the eye. We also have a lot of blood cancers and lymphomas, dealing with the lymphatic system, Burkitt's lymphoma and non-Burkitt's lymphoma. Yes.
How exactly do you go about understanding where help is needed most, where prevalence of cancer is highest in the country?
Sadly enough, when it comes to chemotherapy, there are a lot of chemotherapy centers across the country. But when it comes to radiotherapy, there are very few public institutions that offer comprehensive cancer treatment, including radiotherapy. I think at the moment there's only 2 or 3. So for the longest time, anyone who had cancer and needed radiotherapy was sent to Kenyatta National Hospital. So you find the bulk of the children, wherever they're from, at some point either end up at Kenyatta Hospital or in the private institutions for those who can afford.
Do other facilities across the country have this capacity to actually deal with this? Let's say now we have a KU teaching and referral hospital. We have Moi teaching and referral, or the county level 5s. Are they able to deal with childhood cancer?
Yes and no. When it comes to chemotherapy, which is basically just getting your cancer drugs through the IV, that's okay. When it comes to surgery at a certain level, some of them are able to cope with them. But when it comes to radiotherapy, it's very difficult because unless you have the machine, for example, Moi Teaching and Referral Hospital does not have that machine. So we have a lot of kids from Moi Teaching and Referral Hospital that get referred to us and they have to come all the way to Nairobi for radiotherapy sessions.
Now tell us about how what a family goes through, all right? So you have a child, an adolescent, a 5-year-old, 6-year-old who has been diagnosed with cancer and they need to go through treatment. This is chemo. It's going to be done in KNH. You've got to travel to Nairobi. What do they go through? Just take us through that journey.
Before I say that, in terms of statistics, in developed countries, there's childhood cancer survival rate is about 80%. Low and middle income countries such as Kenya, that rate is 20% and below, which means there are gaps that need to be filled. I myself am a cancer survivor. I had cancer at the age of 19. Luckily, my parents were able to afford the best cancer treatment in the country. Some of these kids who come from, whether it is Kisumu or Turkana or Isiolo or Lodwar, wherever they are in the country, number one, there's late diagnosis. That's one of the biggest issues when it comes to childhood cancer, because they will go to facilities where there are no trained oncology nurses, where there are no pediatric oncologists. So for me, it took about 6 months to get the right diagnosis. And this is in, the best hospitals in the country. So these children are told, you have cancer. They don't even understand what, cancer is. So these parents are referred to Kenyatta National Hospital, for example, and they have to come all the way to Nairobi. They don't know where they're going to sleep. They don't know what they're going to eat. They have to be here for weeks on end. Number one, the financial burden is very high. Secondly, the emotional burden of not really understanding. The doctors break these things down in very, very complicated terms. So they'll come to us and tell us, okay, I've been told about chemotherapy. What is that? So we walk them through that journey. Most people who have cancer will go through a combination of different treatments, including surgery, radiotherapy, chemotherapy. Aside from that, you have hormone therapies and other things. So there's a lot that the families go through, and there's a lot of strain. They say that families are pushed from poverty to extreme poverty when they get cancer, because a lot of the time it's diagnosed late, and that is the stage when it's most expensive to treat.
Why the late diagnosis? Are there factors affecting why you would not be able to tell that there was something wrong? Is it because we're looking at children, or why would that be so difficult to diagnose?
As I said, even for myself, it took about 6 months to get the right diagnosis. The symptoms cut across a wide range of diseases. I had flu symptoms, I had nose bleeding, I had very mild headaches. And I started going to see different doctors. I went to Nairobi Hospital, I went to Aga Khan, I went to very many different hospitals. And for about 6 months, I kept being treated for sinus issues until someone told me, why don't you go see an ENT? And I went to see an ENT, and as soon as I told him, he had a high index of suspicion. And he was like, okay, I think I know what this is. We need to do further tests. But not a lot of people have that opportunity, because at the end of the day, they're coming from maybe just a dispensary where they've been told, okay, you need to do this, you need to do this, you need to do this. They're treated for this. And then they're told all of a sudden, you need to go to Nairobi to do some tests. Not because we know what it is, but they don't even have the capacity to do those tests. And they're told it's going to cost this amount. So they either have to sell some assets, borrow money, find money somewhere to come to Nairobi and then to do the tests. So that is one of the main reasons for the late diagnosis. There's not a lot of training at the primary healthcare level, which is something the government has been trying to improve. But we need a lot more of that.
You talk about a particular set of cancers, the lymphomas, the blood cancers, the retinoblastoma that you talked about. If we can just take a moment to look at some of those symptoms, because now being symptomatic then might trigger some folks to say, okay, maybe this is something that I have to go check up on. So what are some things that you would see, or any parent would be able to see in children, or caregivers in children, that could then say, maybe we need to have this looked at?
That's a good question. Number one, for retinoblastoma, which is a cancer of the eye, examine your children's eyes. Just be very keen. Keep looking at them. If there's anything that looks off, if you're seeing some strange reflections in the eyes, if the eyes are changing color, that is something definitely to be looked at. Aside from that, childhood cancer symptoms include, for example, lethargy. Like you have a child who is very, very active. All of a sudden, he doesn't want to play. He doesn't want to go outside. He just has no energy. That is something you should, look further into. Persistent headaches, persistent vomiting, swellings and lumps, bone pain. You just have to be very attentive to what your child is saying. A lot of the time we think, this one just doesn't want to go to school or whatever it is. But if it's something persistent and they're behaving in a way that they don't normally behave, because a lot of the time the child can't communicate properly. Like I told you, the youngest child we're supporting is 3 months. He's not going to tell you I have a headache. So just be very attentive to your children. Look out for those signs. Anything that is out of the normal, even if it just seems like, it's just a nosebleed or it's just a headache, let me drink some water, take some Panadol. But if these things keep coming and coming and coming, it's definitely something to look at. Yeah.
We keep hearing of cases where, cancer patients have to travel, to Nairobi or to the major towns where the big facilities are, and then they have to join a queue because of the machines available. Let's say we're talking about radio and the machines available, there's a long queue for it. Do you have any preferential treatment that the children get in such cases? Like, so this is a child, so we're going to give them going to help them jump the queue.
That is tricky. And I know what you're talking about because about 3-4 years ago, the radiotherapy queue in Kenyatta National Hospital was about 2 years. And that is the treatment cycle. Some of those children, within 2 years, they won't be here anymore. And what has happened is the government has become very purposeful about increasing the centers where they can get treatment. Unfortunately, you will go to Kenyatta and there will still be a line, but it's getting better. There's more training going on, and they're also opening a lot of centers outside of Nairobi to kind of try and reduce those numbers. But at the end of the day, it is still a problem. For example, for NHIF, you know that you have to wait 3 months for it to be active. Luckily with us, we have signed an MOU where they reduce it to 1 month for us. But sometimes that 1 month is still too long for the child to start getting treatment, depending on what type of cancer they have. So there are things that we are working on. We still have a long way to go, but at least we're moving in the right direction.
There's something that always puzzles me about cancer treatment, and that is, it seems to be on the increase. Is it that more people are being diagnosed with cancer, that we are better able to determine that it is cancer? Or is it something that is causing the rate of cancer to increase in the country? What is it?
I think it's a combination of what you were saying in terms of a lot more doctors are being trained, a lot more nurses, a lot more people at the primary healthcare level, whether it is a dispensary or a level 1 hospital or a level 2 hospital, to be able to have a higher suspicion of higher index suspicion. So basically, people are being trained, so you're catching more and more cases. I do believe personally, I don't have facts to prove it, that there are a lot of people who used to die of cancer that was undiagnosed.
Sure.
And because, you're there in the village, you're told you have this thing, and people, they don't know what this cancer is, so they hide you in the house.
Witchcraft.
Yes, exactly. You did something bad or blah, blah, blah. And I believe that a lot more people have a higher index of suspicion at the primary healthcare level. So we are getting a lot more referrals. And there's a lot of advocacy going on. We go into the community, we talk to people in the villages, we have a lot of outreach. So we are trying to sensitize people at the grassroots level to know that this thing called cancer exists. This is what it is. It can be treated, but it has to be caught early. We're even telling people, if you go into the doctor's office and, for example, you've been treated for sinuses for 3, 4, 5, 6 months and nothing is happening, question the doctor, get a second opinion. We shouldn't look at doctors as gods as we used to. They used to be like teachers, or how we used to, when they tell you something, we should be able to question our doctor. We do have rights as patients. And that is something that we are trying to put into people's minds. But going back to your question, I do believe that it is increased training, a lot of advocacy in the civil society space, and basically just also being in the right place at the right time.
With diseases, there's always the discussion of the prevention aspects of it. Is there such an aspect with cancer?
There is such an aspect with cancer. You can take preventative measures. There are certain things that have been proven to increase your chances of getting cancer. Smoking, for example, increased alcohol intake, and also people promote, physical fitness, healthy lifestyle. Your immune system is healthier. If anything comes, it should be better equipped to fight it. But with children, they're too young for these environmental factors to have any impact. So by the time someone is 3 months old, you can't say it's because they were unfit or because, they were drinking or smoking. So with children, it's much trickier, which is why we have to be even more vigilant, because as an adult, you can do a breast exam, you can go and do your mammograms, you can go and get your prostate exam. But as a child, we just have to, continually look at how is this child developing, what are the things that are looking abnormal, and what can we do about them.
I think I'm still stuck on looking at the support then when it comes to treatment, radiotherapy and chemotherapy. We talked about the fact that chemotherapy available maybe countrywide, that wherever you are, you can have access to that. But unfortunately, the treatment is coupled, radio and chemo. And if we only have that available in 2-3 facilities in the country, then that's a huge challenge.
It is.
Where is support then? We've rolled out UHC the last 1 week. Where is the support, state support for having a lot more facilities then with the radiotherapy element included?
Unfortunately, with radiotherapy, the machine is very expensive, and it takes a long. I think MTRH and Eldoret have been trying to get a radiotherapy machine for I think the last 5 years. But there's a lot of things that go into it, and there's a huge budget that comes with it, from human resource training to transfer of knowledge in terms of technology and how to use it, to actually purchasing the actual machine, maintaining it, and things like that. What the government is doing, for example, in the National Cancer Control Strategy that was launched 5 years ago, I think this is the last year, every pillar has a write-up on childhood cancer and what should be done. So when it comes to on paper, these things are there. It's just now it's been hard to implement because of budgetary issues and things like that. So I do believe that with time things will get better, but we also need to also not look at it as a government problem. We have a lot of corporates in Kenya. We have a lot of well-wishers. We have a lot of donors. Why don't we come together and make sure that at least in every, I wouldn't say county because those are too many, but we used to have 7 provinces in Kenya. Why not in every province can we have a radiotherapy machine, whereby someone doesn't have to travel all the way from Turkana to Nairobi to be here for a 30-day radiotherapy cycle, doesn't know where they're staying, doesn't know what they're going to eat, has 5 other kids at home. You've moved from a double income family to a single income family because the mother is now the primary caregiver. And if, for example, you had that close to home, you'd be able to still do your job, take care of the child, take care of the other children at home. We have cases where families are separating because you have 5 other kids at home. This is cancer. That kid is going to die anyway. Let's take care of these 5 other kids. And these are the mindsets that we're trying to change.
These are the difficult conversations that are taking place in households. Sidney, you've talked about very many things that the government is doing. Government has been working very hard at training more doctors, and the government has been trying to increase the number of facilities that offer care for cancer patients. NHIF and revamping NHIF and making sure that NHIF can then finance a lot of these costs. But then you talk about the high capital expenditure that's required to get some of these machines. And that has been a bottleneck for the second largest referral facility in the country, Moi Teaching and Referral, has been trying to get a machine for the last 5 years, to the best of your knowledge. I mean, do you really buy that story that, it's been very difficult to get the resources to buy the equipment that is required to treat cancer, and we can see the increasing number of cases?
That is a tough question. I think there was an Abuja declaration in 2019 whereby countries decided that we're going to be at least 15% of GDP is going to go into healthcare. I think by 2020, Kenya was only putting in 5%. And when we say healthcare, we mean healthcare across the board. Not cancer specifically, not childhood cancer, healthcare across the board. So what happens then and how is it allocated between the different diseases, non-communicable diseases, HIV and AIDS, things like that? I think what needs to happen is we need to have an approach where, like 10 years ago, everything on the radio, on TV was about HIV and AIDS.
Yeah.
There was a lot of push by the government to go out into the international community and get funding to start producing, making HRVs freely available. Right now, People are living 20, 30, 40 years with HIV. It's not a big thing anymore. So I believe we need to take that approach and say we need to push in as much funding as possible so that we can train more doctors, create more awareness, and have these facilities fully equipped to be able to comprehensively cover cancer. And what I'm pushing for is for the government to join the Global Initiative for Childhood Cancer, whereby WHO is trying to increase the survival rate of children worldwide to 60%. As I told you, in Kenya, it's about 20% and below. So something like that would really help when it comes to childhood cancer and cancer in general, because now you put in systems and structures, but also bring in the funding that is needed to push cancer to the next level, childhood cancer care to the next level.
Today is International Childhood Cancer Day, and we're highlighting the childhood cancer. Joining us in the studio is Sidney Chahonyo, the board chair of an organization called Hope for Cancer Kids. They work with families. They support children who are undergoing treatment for cancer across the country. And we're talking about the prevalence. We're talking about the support that they require. We're talking about the numbers, the challenges that people go through. Sidney, you're telling us that one of the things that you do is those that are unable, you help them to raise the money to for NHIF, to subscribe for NHIF. So then it sounds like NHIF is really doing a good job or a big job in helping to finance the cost of treatment for cancer. Tell us about that.
Yes, we do support the children by paying their monthly premiums, and then they're able to get NHIF support in various public hospitals and get comprehensive cancer treatment. However, NHIF is limited. For example, you cannot register a child on NHIF. You have to register them under their parent. I come from a family that has 6 children. So that money is limited. So all of a sudden, NHIF, for example, limits to 6 surgeries in a year, I think. So let's say there's this one thing called examination under anesthesia, which is a diagnostic test for a type of cancer. And you need about 2-3 of those every couple of months. And it's termed as a surgery. So you can only have 6 surgeries in a year. All of a sudden, maybe someone else gets sick and needs surgery, someone gets into an accident. So there are limits to what NHIF can do. They're doing a very good job. But a lot of things, for example, last week I had a child who was 17-year-old. He has cancer and he needed 33 sessions of radiotherapy. And NHIF caps it at 20 sessions. So he finished his 20 sessions. He was supposed to continue on World Cancer Day, actually. On the 4th, he was supposed to do his 21st session. He didn't have the money. He reached out to us and we had to look for donors to come and support him and raise, I think it was 54,000 for the remaining 13 sessions. So NHIF is doing a good job, but a lot more can be done. I'm not saying it's a government problem. It's a problem that involves each and every one of us, whether it is the civil society, the government, NGOs, private institutions, corporates. We need to find a way to work together to make these things happen, which is why we partner a lot with organizations such as, for example, Lions Club International. Last year, they gave us enough money to support, I think it was 700 kids for the whole year. Some of these other things out of pocket, transport, accommodation, and things like that, still have to be paid for. You reach a point where your NHIF reaches its limit. You have begged, you have sold land, you have done everything you can. Your own relatives are not even picking your calls anymore. And you still have, to treat for cancer. And the longer you stay between treatments, the worse it gets. Another issue we face, especially with children, is nutritional support. When you're in the hospital, you're getting 3 square meals a day. You're getting supplements. All of a sudden, you go home after one cycle of chemo to come back a couple of months later, and you're coming back in a worse state than when you left the hospital. Yeah. Not necessarily because you're not getting treatment, but even at home, what are you eating? Are you getting 3 square meals a day? So there are a lot of issues that go into that, and I do believe improvements could be made to the NHIF system, but we also need to find other ways of making this holistic cancer care available across the country.
In your experience, what would you say is the success rate of cancer treatment in Kenya?
When it comes to childhood cancer,
yes.
As I said, in developed countries, success rate is 80%, the survival rate.
Yes.
In low and middle income countries such as Kenya, it's 20% and below. Why is this? Late diagnosis, lack of access to treatment. Sometimes it's treatment abandonment because you have reached your end. You need another 60,000 to go for the next session. You don't have it. You've sold your shamba. You've done so. You just abandon treatment. Keep the child in the house. We have cases where people abandon their kids in the hospital and say, "Okay, let me go back home and look for money. At least here I know he'll be taken care of. When I'll get to the bill when I get to the bill." So a lot of it is financial pressure on their families that cause them to abandon treatment. Yes.
You know, it's rather daunting when you think about it, the enormity of it. And how many radiation machines did you say we have in this country?
Pardon?
Radiation. Radiotherapy.
Radiotherapy machines are plenty in private institutions.
There are plenty.
Yes, a lot of private institutions have them. In the public space, where more than, I think, in my opinion, 70% of the population would go, at the moment, I think we have 3 or 4 functioning radiotherapy machines in different centers.
So the president was launching one in Mombasa last week as he was rolling out the upscaling of universal health coverage.
At Portuguese?
Yeah. So there's one. MTRH, let's say, has come online. Kenyatta University Teaching and Referral, have been talking about having one.
Kenyatta
Hospital then has. So you ask yourself, and this is a question that Dr. George got, our friend from Kisumu, is saying, the country desperately needs equity in the distribution of national teaching and referral hospitals. For example, for 60 years after independence, why are we just proud of KNH, MTRH, KU teaching and referral? That's not enough. How about in the other countries? How about in other places? Even talking about the cancer centers. Plans are still in plans to have those centers developed in Mombasa, in Nakuru, in Garissa, and other parts of the country. It's like you're saying, it's not only a government problem, but who else needs to sit around the table and have this conversation so that we can speed up this?
The government has been gracious enough over the last couple of years. We used to make a lot of noise, and they just used to push us aside. But they have realized that the civil society has a big say, because a lot of the time we deal with the patients one-on-one, and we understand their needs better. So when they were developing the last National Cancer Control Program plan, the strategy, they invited a lot of civil society organizations. Let's sit down, let's find out what the needs are, what we need to do, and how we draft the strategy. So we had input there. So they're starting to invite us to these decision-making forums. At the end of the day, we also have, sadly, the international community. I really believe that we should be able to sort out a lot of these problems in-house.
Isn't it?
But the international community has a lot of goodwill. As long as it's a good program and it's making an impact, a social impact. We do have a lot of donors from outside who want to do things in Kenya, come into the country. Sometimes they get frustrated because, of the systems and structures that are in place.
Yes.
But you also have a lot of international organizations doing a lot in Kenya. But where are the corporates?
Kenyan
Where
corporates.
are the Chandaria Industries? Where are the Safaricom foundations? I understand that a lot of people have different goals, different visions, and different things that they support. But cancer is one of the top 3 leading causes of death, among the top 3, whether it is adult cancers or childhood cancers. How much money have you spent on COVID-19?
Right.
It's killing a fraction of the people. Every 3 minutes worldwide, a child dies of cancer. Every 3 minutes. We don't know the statistics in Kenya because there's no childhood cancer registry.
Sure.
And there's also no national cancer registry. There are 2 or 3 registries in the country, but we need to get a lot more information. We need to get a lot more research done to push for, because a lot of the time you'll go and say this needs to be done. You'll approach, let's say, the government or whoever it is you approach, and they say, give us the numbers.
Right.
Prove
For
it.
them to.
Yes.
So even as you say this, a national cancer registry for children, a national cancer registry for cancer.
Integrated, yes.
Integrated.
Yes.
What or how would we benefit from having a children's cancer program instituted by government, supported by others, whether those are internal or external supporters? What do you see that it would allow to do? Because I'm just looking at all the things that we've said that pose as challenges today, from getting these young ones treated when they unfortunately do get cancer, what would be the benefits of instituting a program from government level?
What happens is, number one, if a lot of things that we are trying to do need a lot of goodwill from the government, support from the government. So even if I'm doing something in the civil society, there are times when I need certain concessions from the government, or this to be done, or even just, to have an open door.
Sure.
To walk in and talk to them about the challenges we are facing. So what this would do is, number one, if you have a national cancer registry, you have the actual statistics. And then you can go back and say, okay, look, X amount of children are dying from cancer. I think right now, the extrapolated data says that out of about 47,000 cancer cases in Kenya, we have 38,000 deaths. These are extrapolated, and not all cancer cases have been reported. So we need those statistics so that we can be able to say, this is what we need to drive.
Or in
And
this
then-
particular area, we have a higher
Exactly.
prevalence of cancer.
Yes, yes.
How about we invest in a machine?
Yes, yes.
that,
Or
yeah.
even, this area has a prevalence of this particular kind of cancer.
Right.
Why is that the case? And then you also have an integrated system where I am treated in MTRH. I'm referred to KNH. A lot of the time, a doctor will say, we need to do our own tests here to verify this and that
That
and that.
again, yeah.
So that's another out-of-pocket expense. If we had an integrated system whereby you go to, you are diagnosed at, Nairobi Hospital. You went to Mata Hospital for this test. You went to Aga Khan for surgery. So that by the time even the doctor is getting you information, even if you were treated in a dispensary somewhere out there,
All the
there's a
information
history
is
of
there.
something.
Right.
So that high index of suspicion, this plus this plus this, there must be something else. So that we can start catching these cases early. But also at the same time, to be able to drive the push for more funding to be put into these programs. Yes.
Preventative care is often something that we talk about. There's certain things that you can do that could, fend off disease. Are we looking at the same? And preventative care has also been mentioned when it comes to cancers. Even though you may not know the cause of it, that maybe there are certain things that you could adopt that could then later on prevent. We've seen HPV for cervical cancer, for example. When we're looking at child cancers, is it possible, if you have a 3-month-old, what would you have done in 3 months to prevent this child from getting it? Is there the preventative outlook here
As I
as
said
well?
before, when it comes to children, studies have been done that say that as a child, the environmental factors have very little or no bearing on you getting cancer. A lot of the time they say it is just because of their increased growth, they have a higher chance also of the cells dividing abnormally. And studies have been done that say this and say that. So in terms of preventative measures for children, there's very little you can do. Aside from that, you mentioned the HPV vaccine. It is being rolled out for free in public institutions. It's targeting girls aged 10 to 14. Cervical cancer takes about 10 years to develop.
Yeah.
So by the time it has turned into cervical cancer, something has been in your system for about 10 years. This HPV vaccine will come in and limit your chances of getting that cancer. By the way, there are about 5 other cancers that it also protects against.
Right.
Cancer of the vulva, I forget the rest, but there are about 5 other cancers that it also protects from. And these are some of the things that we need to start looking at. But also, I think just going out there into the community and telling people cancer exists. It is real. But if it is caught early, detected early, and you have access to treatment, it can be treated at a relatively cheaper cost. And that is the message I think that we need to push out there, that cancer is out there, but it is treatable. And we need to find a way to integrate these systems in a way that people are working together, as opposed to, I'm trying to do this, or, oh, government, you're not doing anything. We need to find a way to work together.
Sure.
Because it falls on all of us.
What do we need to do to improve early detection?
70%, about 70 to 80% of childhood cancer cases are recorded in low and middle income countries, such as most of the countries in Africa. And that at-risk population, we know that in Africa, I think there's a large proportion of people under the age of 35.
Yeah.
This is the workforce.
Yeah.
And if you lose these children, children are precious. That is why the gold ribbon for childhood cancer is golden. This is our future. What do we need to do to improve this? We need to have a lot more dialogue, number one. Open dialogue, starting from the ground up. Starting from the support group of the parents who have cancer. They know the needs they have. They know the gaps in the system. Yes, the government is doing this, but can we sit down with this group of people and find out where exactly the problem is, where exactly the need is, so we know how better to focus our efforts. As I said, unfortunately, it also comes down to finances. We need to invest a lot more into healthcare and into cancer specifically. Because at the end of the day, if you catch cancer early, it's much, much cheaper to treat. So a lot of the people who are being diagnosed right now are being diagnosed in the late stages, stage 3, stage 4. Why? It's very expensive and NHIF cannot cover it. But if you caught it early, most likely you would have had a shorter treatment cycle and you would have had less invasive treatment. Therefore, you're catching it early and you're treating it at a cheaper rate.
Right.
So we even need to talk to the insurance companies. For the longest time, there was a time I was trying to apply for insurance. I went to 3-4 different insurance companies, and the minute they see cancer, they write you off. Obviously, they don't tell you we're denying it because you have cancer, but it's very evident. So we need to get all these parties on board: private, public, even the international community. We have WHO representatives in Kenya. Have we reached out to them as government to see how best we can work together? Which is why I'm pushing for Kenya to apply to be one of the pilot countries in the Global Initiative for Childhood Cancer, because there's a WHO rep here. WHO has a goal to increase childhood cancer rate to 60%. Where's the connection?
In fact, now that you've raised that important question, let me raise another one. We have in our universities certain institutions that train our medics, our medical doctors, our clinical officers, our nurses, and specifically the universities. Do you know of the extent to which these universities that teach these courses in medicine encourage research into cancer? I'm mentioning research because I know with research, a lot of the problems that we're talking about get nipped in the bud because your understanding of the disease becomes greater than it normally is. Do we have such a preponderance? Do we have such a move in this country where there's a growing interest in research? Because one of the things that if you look at research funding around the world, specifically in the US, National Institute of Health, there's a lot of funding for cancer research. Do you think that our institution, do you know if we take advantage of some of these things?
Yes, research is pivotal because at the end of the day, it drives the decisions that are made.
Yes.
It brings the pertinent issues on the table. Right now, as I said, there's not much research being done, especially when it comes to childhood cancer. And these are some of the reasons why when you approach people to say we need to do this, they ask why. And you go and you say that we need to do more research into this to find out, to drive the decisions that are being made or to push the drive for ABC, X, Y, Z. A lot of the research, even these statistics, a lot of them that we get, if you look at any papers on childhood cancer in Kenya, there's maybe 1 or 2 studies that have been done. Okay, maybe more than 1 or 2.
No,
but the proportion is very low.
The impactful ones are literally that 1 or 2. The ones you look at and you say, okay, detail went into this, somebody bothered to actually try and give this thing a broad-based approach.
Yes. And which is why, sadly, I keep going back to the government. And yes, these institutions, civil society organizations, we need to push for more research to be done into cancer in Kenya, and specifically, I'm biased, childhood cancer.
Sure.
Yep. Several comments coming in from doctors who are tuned in this morning. Dr. Abi Mwachi says it would help to have specific centers of excellence spread across the country. It's unreasonably expensive to imagine that each county can have the capacity to treat all diseases. So if we said, for example, in this region, we have this facility that is a center of excellence for these type of diseases based on the disease prevalence and the disease burden in those areas, then that makes it cheaper and more easier to distribute. Dr. Ero says strengthening primary healthcare would capture early diagnosis of cancer, and this includes sensitization, educating a community about predisposing factors. I studied in a country which had annual compulsory screening of so many things, and foreigners were not left out. And then also Dr. Ogot says he's a practicing head and neck cancer surgeon, and he says, I'll tell you for free. This foundation of an effective cancer care system is an effectively working government hospital system that's staffed with qualified doctors to the lowest levels, at least to the health center level. Machines will not replace the proper human clinical acumen that eventually selects targeted investigations. So long as our public hospitals are not working optimally, no machine will help us turn the tide. There cannot be an isolated functional cancer care system without an effective public hospital system.
I think that's very interesting. And then going on to probably the next question is because, again, last week we've seen the national rollout of UHC. And here we are saying that there's this, swanky new system that we're going to be able to use to treat and then to also offer healthcare in the country. But the infrastructure then, greatly lacking. And I continue to have a struggle with that. So here we are saying that there's this huge need in this particular part of the population. But then the infrastructure is lacking then in how we're going to be able to deliver this. Are these some of the challenges that you see? And what would you hope then that UHC would provide in terms of additional care for these children?
UHC is a very good concept. I like what Dr. said when he said, at the end of the day, you can have all the machines. But if you don't have proper training at the primary healthcare level, if you don't have enough medical, pediatric oncologists, radiotherapy technicians, if you don't have the workforce to, number one, catch it early and be able to find out the best way of treating it, then yes, the machine is not going to help much. But at the end of the day, if you have the best doctor, you've diagnosed it early, you've caught it early, you know what kind of treatment you need radiotherapy, you refer me to KNH, I'm waiting there for 6 months to start my radiotherapy. Some of these cancers in children can double in 1 week. So it's a holistic approach that is needed. And as I said before, yes, it would be too expensive to have it in every county, a radiotherapy machine, but if you look at the old system of provinces, we have more than 7 radiotherapy machines in the country, just that most of them are in private hospitals, which not many people can afford. If you tell me to go and do a PET scan, and I don't even want to mention the amount of money that it costs to get a PET scan. Who's going to afford that?
How much is it to get a PET scan? How much is it to get a PET scan?
I think it was something like 60,000 at the minimum. I stand to be corrected.